Dr. Lee, and congratulations on such a momentous achievement that you have spearheaded. That's been over 40 years due.
Yeah, actually, when I started this project, I had no idea how behind we were. Initially, I got involved. I was a liaison for AAGL for the ACOG Coding and Health Economics Committee. And my primary objective initially was to help to improve different procedure codes for endometriosis. And obviously, it was a lot of obstacles.
Yes.
And then it was not easy. And then somewhere a few years down the road, they asked me if I'd be interested in helping revising the endometriosis diagnosis code, the ICD-10 codes for endometriosis. And I said, sure. I had no idea that we did not have the actual codes for a lot of codes for endometriosis, because every time you're in electronic records, when you type in certain diagnosis, it automatically give you auto-populated and give you the what you thought was a diagnosis. But when you read behind the alphanumeric code behind each of the descriptions of that, what I just put in, it's the same code.
Right.
And so so I began to realize it's actually that we had a big problem. And so initially, obviously, I want to create a code for deep excision of endometriosis. And then when I realized that if you don't even have a diagnosis for deep endometriosis, how can you create a procedure code for it? So you need to create the egg, then the chicken, or vice versa, right? And so it's become important for me to say, okay, well, this is something that's very important, and it's for me it was a low-hanging fruit, because I was working with CDC, and then there was actually my first interaction with them was quite surprised me. I was very well received when I first did the first presentation for them, and they definitely feel that this is way overdue. And the rest of it mostly like the formatting, how things should be fit into the ICD-10 format, and then that's why there are a lot of revision going back and forth. But really, like from the very beginning, I knew that this is going to go through, because I was the very first meeting. It was very well received by the people in the panel. Of course, this is all virtual at that point.
Wow.
So for the laymen who don't understand what all this coding means, so initially I was going to work on the procedure code for the surgery part, okay? And obviously it didn't go anywhere because there were a lot of obstacles that was in my way, and I won't get into it too much. If we have time, we can get into a little bit more. But what I had worked on with the CDC was actually on the diagnosis code, okay? For example, if you have endometriosis in your bladder, or you have endometriosis in your diaphragm, with the current coding system in terms of the diagnosis, is the same, because they don't. Each one of them did not have their own. They did not have their own code. The bladder endometriosis does not have a code. Diaphragmatic endometriosis does not have its own code. If you have endometriosis on your sciatic nerve, it doesn't have its own code. So all that fall into this wastebasket of other endometriosis. And so if you want to study the epidemiology of diaphragmatic endometriosis, what's the prevalence of diaphragmatic endometriosis? You won't know. You just people told you it's very rare. But if you search for the hospital records for the diaphragmatic endometriosis, you won't find it, because that would be characterized under other endometriosis. And so, and also that's one of the things that happens with the current code, is that there's so many codes that we should have but didn't have. And if you have endometriosis of your bowel, of your small intestines, your rectum, your sigmoid colon, or anywhere on your GI tract, there's only one code for that. Right. And then with the new code that you would have the representations of different segment of your bowel represented in the new code.
So as you said, this would also change so much in terms of even just medical research to know how prevalent certain and where endometriosis might be. If bowel is, let's say, 1 in 2 times or something like that along those lines, that it would help physicians to understand the disease prevalence better.
Right, exactly. And then that was also to help with the allocated research dollars as well. If something doesn't exist, or if if you don't have a code for it, it doesn't exist, basically, right?
Right.
Right. So then there are things that you'd be able to track the disease better, and you will see the be able to see the prevalence of the disease. Also, too, is right now, even though that we won't have a procedure code for a lot of the surgery we perform, but when you do the surgery, you're able to characterize where all the endometriosis is located and whether it's superficial or it's deep. So there's laterality to the code. For example, if you have endometriosis on your left pelvic sidewall, or you have endometriosis on your bilateral pelvic sidewall, there's laterality within the code itself. So you'll be able to from the code that we put in there for our post-op diagnosis, you will know exactly how much endometriosis the patient had.
And how does this relate to insurance companies that have been hesitant to cover things that are not considered? They'll say that excision surgery is not necessarily needed, extra pelvic operations that are due to endometriosis are not necessarily needed. Will these codes in any way help facilitate change there?
Well, so I think this is a misunderstanding. Is the insurance, they'll pay whatever the codes that exist. Okay. So right now, the current code for endometriosis treatment is a pretty much one size fits all, right? So the current code is 58662. That can include ablation endometriosis or excision endometriosis. It does not distinguish that. It doesn't distinguish how much disease the patient have, right? So if you have lots of endometriosis, need to excise lots of endometriosis from both pelvic sidewall, the cul-de-sac, the bladder area, and so on. The current code does not give you that distinction, right? And so the insurance said, well, we pay for 58662, but that can range from 5 seconds of ablations to 5 hours of excision, right?
Right.
There's no distinction. So that's what the big problem we have now, and that's really is I think hopefully after you have the diagnosis codes now, then we can begin to work on the actual procedure code to provide different levels of endometriosis surgery. Because certainly, it's like if a patient have very mild endometriosis, it takes less work.
Yeah.
If patient have a lot of endometriosis, takes lots of work, and we need to be able to have a way to distinguish different level of care for endometriosis surgery.
Right, right. For the physicians and also for the patients, because when you mentioned as well that the physicians that are getting paid per this one code, which is not a simple surgery. When you have bowel obstruction, you could have ureters involved and so many other things. When we mention extra pelvic, lung collapse, those are not simple surgeries. So this diagnostic code, like you said, can lead to procedural codes. This can be a very big change for physicians and patients alike, so that patients can also get the right coverage instead of fighting tooth and nail for what is necessary surgery. But due to improper past coding, they've had to really wage a war against insurance companies to be able to cover what they need to for further surgery.
Right. So a lot of codes doesn't exist. For example, a lot of code currently exists as an open abdominal surgery code, and there's no laparoscopic equivalent of the code. Okay. So for example, if I had to free up the ureter, that's in case of endometriosis, and I perform a ureterolysis, right? That code does not exist. That code only exists if I just do an open surgery and I free up the ureter. Okay. And so currently there are so many laparoscopic surgery codes that we should have, but we don't. And then it end up become an unlisted code. And whenever a code is unlisted, it's automatically rejected by insurance company. It's automatically rejected by Medicaid, because Medicaid does not accept unlisted code, period. And that, in my mind, also create bias and discrimination.
Yes.
Yeah, because if you are doing procedure for Medicaid patients, which I have a lot of patients with Medicaid, okay, and I accept them, but then you get no credit for the work that you've done, even though you take a lot of risk and time to perform the procedure. And it's problematic, you know, and I'm just hoping that this will be serve as a basis down the road that we will be able to create a lot of a new additional procedure code as a result of the additional diagnosis. But that will take some time to occur, obviously.
Yeah, well, hopefully it won't take another 40 years. And I'm very grateful on behalf of the 1 in 10 that have this disease, that something has been done. I was not thinking it would happen in my lifetime. So it was a monumental moment, and a bright future ahead, thanks to your work and the work of your colleagues. So thank you for carving out a little bit of time to explain the codes, what they mean, what the future looks like because of this. I do hope when you have more time that you'll come back and join us, because I think there's much to discuss. There's so many intricacies here.
Oh, thank you. Thank you.